Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the second part of chest. Last time we have reviewed chest radiograph, which is showing abnormality, and I asked you to answer it. Let's review the image. Here is our image. This is the image which have been shown previously. If you notice, there is small linear fractures in multiple ribs over here. These are rib fractures. This is the case, rib fracture. Regarding rib fracture, here our label. Rib fracture typically occur as a result of high energy trauma in the young and low energy trauma such as fall from height in the elderly. Posterior rib fracture in a child are often a result of non-accidental trauma, usually an infant being squeezed in two hands. If 3 or more consecutive ribs are broken in 2 or more spots, there is risk of flail chest. Flail chest happens or occur when there is multiple ribs is broken or fractured in more than one side, which a section of chest wall moves paradoxically. Means that there is a part of the chest wall moves inside and outside. Again, X-ray findings, non-displaced rib fracture are easy to miss but will usually appear as loosened fracture line, as in our case here. These are the loosened fracture lines. Ultrasound and CT can be used to detect fractures if X-ray are unrevealing and clinical suspicion is high. Management of rib fracture, solitary non-displaced rib fracture are treated symptomatically. Flail chest is managed when pain control and pulmonary toilet. If patients continue to have respiratory insufficiency, mechanical ventilation can be considered because of the risk of underlying lung contusion in case of flail chest. Then let's move to the next pathology. Aortic dissection. Aortic dissections occur where the proximal aorta or thoracic aorta have an injury between the two layers of its wall, the intima and media, or the adventitia and media. When aorta is ruptured, we have wide mediastinum. This is the normal contour in red line, and after aortic dissection, it is in green color, widened aortic knob or widened superior or anterior mediastinum, because aorta in posterior mediastinum, the aorta is located. Let's review this. An aortic dissection is a separation of the intima of the aorta from the media, the two layers of the aorta. The most common risk factor are chronic hypertension, connective tissue disorders, and pregnancy. Because in chronic hypertension, connective tissue disorder, and pregnancy, there is a risk either related to the components of the wall of the aorta or the vascular walls, or increasing the pressure inside the aorta, like in cases of hypertension and pregnancy. Patients classically present with a tearing chest pain, very painful or severe chest pain that radiate to the back and migrate inferiorly as the dissection progresses. They can also show signs of cardiac tamponade, cardiac tamponade means the presence of fluid within the pericardial space. Pericardial space, which is a potential space between the two layers of visceral and parietal pericardium, looks like pleural effusion in case of the thoracic cavity. Cardiac tamponade is very dangerous and it is top emergency because the risk of cardiac movement stoppage due to surrounding pressure of the fluid. If the dissection track backward and surround the heart, because dissection is the flap, the intimal flap within the dissection can extend to the coronary vessels of the heart, where cardiac tamponade can occur. Neurologic signs or other signs of organ dysfunction can indicate the other vessel have become occluded or are dissecting. In this X-ray, our findings are: on plain film, widened aortic knob more than 8 cm on portable film is the most common sign. An irregular aortic contour may also be seen. Management: get a CT angiogram for definitive diagnosis if it is a type A dissection. Type A dissection involving the ascending aorta. At once type B or the descending aorta is involved, then we have other types than A, like type B and C. Usually managed surgically. If it is type B, managed medically, because ascending aorta is crucial. Moving to the next pathology. After aortic dissection, we have review foreign body. Let's move to clavicular fracture. The clavicle is the anterior upper chest wall bone. The most common site of clavicle fracture is the junction between the lateral 1/3 and the medial 2/3. This junction is the commonest site of fracture. Our X-ray finding over here: 75% of fractures are at junction middle and distal thirds of fracture. Presentation caused by trauma, including fall on overstretched hand. This is push. Step off of clavicle may be present on exam. On exam means here on our radiograph. The management of clavicular fracture: look for other bony injuries and pneumothorax, internal fixation if there are significant displacement, communication, shortening or angulation. Otherwise, sling and immobilization of fracture of 8 wrap until repeat chest X-ray show healing 4 to 6 weeks. Keep in mind that X-ray is not 100% sensitive. If it is so linear or like a crack, maybe we aren't able to visualize it in X-ray. If clinical suspicion is high, get a CT or treat empirically. This is regarding clavicular fracture. Moving to heart failure. This is a patient who has got heart failure. If we notice, the normal chest X-ray have the lung fields bilaterally are slightly blackened bilateral, but in heart failure due to edema, we have some reticulations or reticulonodular opacities. Also, we have curly B lines. Curly B lines means the presence of pleural effusion or fluid between the interlobular septa. It appears as horizontal lines. This is the curly B lines. Curly B lines means the thickening that involve the interlobular septa. Also, we have interstitial edema. This is reticulation, where we have seen before. This reticulation, whitening on both lung fields, unlike the normal lung shadow. This reticulation is the interstitial edema. Then we have another sign, cephalization of pulmonary vessels. If we notice the vessels going toward the cardiac silhouette, these vessels are more vertical in case of pulmonary vessels, cephalization in case of heart failure. The last one, which we have discussed before, a large cardiac silhouette where the cardiothoracic ratio is increased. Presentation of heart failure. Congestive heart failure bilaterally has many etiologies and many manifestations. It is generally divided into heart failure with preserved ejection fraction and with reduced ejection fraction. X-ray findings, the cardiac silhouette can be enlarged to more than 50% of the width of the chest on PA view. Pulmonary edema may also be present, as well as prominence of the pulmonary vasculature. If the vessels are especially visible toward the apex of the lung, this is termed cephalization and reflect elevated left atrial pressure, because the pulmonary veins drain to atrial pressure. Management will be discussed in other settings. We have multiple lines within the chest radiograph can be visualized, like central line, endotracheal tube, and NG tube. Starting with central line. Central line normally should be placed in this side in the red color. Here we have a coiled back central line. If you notice this specification in green line, this is the misplaced central line. It should be in the aortocaval or the atriocaval, in position. Presentation central line should end at the junction of the vena cava, superior vena cava, and the left atrium. The right atrium. This is true for all central lines. X-ray findings, the tip of the central line will not be in the correct position. It might be coiled, be too long or too short, or might track down an incorrect vein. It might descend to the inferior vena cava. The management of misplaced central line. The central line need to be replaced. If it can simply be repositioned. This is regarding the misplaced central line. Next we have endotracheal tube. Endotracheal tube is the tube we use in mechanical ventilation. In this image we have complete opacification of the left hemithorax due to the blockage of the left-sided trachea or bronchial tree, because of the blockage by the endotracheal tube. It descends over the carina, then it results in collapse of left side. Then we have opacified lung on left side, but the normal lung in the right side. Here the endotracheal tube, if you notice again, below the level of the carina, which is misplaced. It should be 2 centimeter to 1 centimeter above the carina. X-ray finding, the tube is seen ending either too far above the carina or too deep. If it is past the carina, one lung will not be ventilated, most probably the left lung, because the right bronchus is more direct with the tracheal continuation than the left. and may be ossified due to atelectasis. Presentation: an endotracheal tube should end 3 to 7 centimeter above the carina. Sorry, I have said that from 1 to 2 centimeter, but it should be from 3 to 7 centimeter above the carina. And the carina is the site where bifurcates the tracheal bifurcation take place. If the tube is too long, it can lead to main stem bronchus intubation, which can cause lung collapse. If the tube is too short, it can lead misplacement of the endotracheal tube. Management: repositioning the tube again. This is the management. Then we have misplaced NG tube. Here we have the NG tube going through the trachea. Nasogastric tube should end in the gastric fundus or body. Here we have the NG tube crossing the trachea to the bronchus and leading downward in the left side lung. This is the misplaced NG tube in purple color, and in red is the expected normal course of the NG tube. Regarding the NG tube, an NG tube should normally be seen overlying the gastric bubble, then crossing the midline as it goes into the duodenum. If the tube is not seen crossing the midline, there is possibility that it was placed into the trachea instead of oesophagus. X-ray finding: NG tube will not be correct in the correct position. It will not cross midline. In the example image, the X-ray, the tube was in fact in the left lower bronchus. Management: replace the tube. How can you avoid this? If you have a patient who need NG tube and chest X-ray in same time, try to insert the NG tube first, then refer the patient to X-ray second, so as you make sure that you correctly place your NG tube. But isn't indication that if you insert the NG tube and then to do X-ray. But if patient has symptoms like choking or coughing, you might think about it after you auscultate the patient chest and make sure you are inside the stomach. This is regarding NG tube. Moving to perforated viscous. Perforated viscous occur when there is patient has risk of ulcer, or in cases of trauma, or due any cause that cause perforation within the viscous. Viscous here means any hollow structure within the body, like stomach and small bowel, large bowel, appendix, all can be perforated. Over here we have free air under diaphragm, if you notice here, and in chest X-ray we have some hidden areas, the abscesses. Sometimes malignancies or masses can occur over here, and the hyla, one of the hidden areas. Retrocardiac, because we can visualize some abnormalities posterior to the heart, and the subdiaphragmatic bilaterally. These called the hidden areas within the chest, okay, in the chest radiograph. So you have to review them before you finish interpreting your image. Here we have free air indicating perforated hollow viscous. Presentation: when any piece of the digestive tract ruptures, it is a surgical emergency. If the rupture occurs in or distal to the stomach, air can be introduced into the abdominal cavity. Patient will typically have peritonitic abdomen from peritonitis with abdominal rigidity and severe pain. On examination appear as tense abdomen. X-ray finding on an erect or upright chest or abdominal X-ray, free air will rise until it is just under the diaphragm. The diaphragm will appear as a thin line of muscle with air on both sides, as opposed to a boundary between the air and the lung and the soft tissue of the abdomen. The management is urgent laparotomy. This is perforated viscous. Moving to pleural effusion. Pleural effusion means the presence of fluid within the chest cavity. Here we have the normal chest radiograph. Here more opacification due to presence of fluid in this side of the chest, obliterating the costophrenic angle. Here pleural effusion with meniscus sign. This sign is the meniscus sign. Presentation of pleural effusion: collection of fluid in pleural space. It have many types. It can be due to pus, which is biothorax, or blood hemothorax, or fluid, okay, such as transudate. X-ray findings: there will be dependent layer of fluid in one or both pleural spaces. If small, it may appear only as blunting of the costophrenic angles, but it can also be so large that it fills the entire side of the pleural cavity. If infected, the effusion may appear loculated. The management range from observation, if minimal, for an asymptomatic effusion, to tapping. Tapping means placement of chest tube and taking a sample from the pleural effusion or fluid collection within the chest by interventional radiology or general surgery team. To tapping the fluid to determine its etiology, to placing a chest tube for drainage. The correct course of action depends on the patient presentation and the probable cause of the effusion. This is regarding pleural effusion. Pleural effusion also can happen in heart failure conditions. In case of trauma, it can occur even with flail chest, for example, or rib fracture according to the site of trauma. Then moving to pneumonia. Pneumonia present as consolidation with air bronchogram. If we see here, these bronchi is containing air. The air is loosened, appear as dark. This dark color, when there is fluid surrounding it, like in pleural effusion we have seen before, the fluid have the density of white, like soft tissue, white color. When the air within the bronchi or bronchiole appear as dark and the surrounding or background is whitish, it seems as we are painting or drawing the air itself. So we call it air bronchogram. Okay, air bronchogram means that the air within the bronchiole is surrounded by radio opaque or whitish background. This is air bronchogram, if you notice again. So here we have consolidation, hazy heart border in right side. That means that the middle right lung lobe is affected because we can't appreciate the middle cardiac border. Okay, so this is pneumonia in right middle lung lobe. Okay. The presentation of the patient of pneumonia: infection in the lung, which typically causes consolidation. It is most common in elderly and immunocompromised, but can affect any age group. X-ray findings: Typical pneumonia will have localized consolidation, and consolidation is the density which obscure the background of the lung. This is consolidation. Here we have the normal side with some reticulations due to some edema, but we can visualize the underlying lung parenchyma. In consolidation, we can't see beyond it the normal side. Also, the increased density of the fissure, lung fissure, can be observed over here. Okay? Because it's the boundary between the right upper lobe and right middle lobe, the fissure. Again, X-ray finding, typical pneumonia will have localized consolidation. Consolidation means the type of opacification which we can't see beyond it, sometimes confined to one lobe. Atypical pneumonia appear as patchy interstitial, as nodular and linear infiltrates. If the pneumonia is lobar, its location can be determined by the blurring of adjacent borders. Mistake here, sorry. The blurring of the adjacent borders. For example, the right lower lobe borders the diaphragm, and thus right middle lobe. PNA here is abbreviation for pneumonia. Right middle lobe pneumonia will cause the right hemidiaphragm border to appear hazy. The management of pneumonia, antibiotic is the mainstay of therapy because we have bacterial cause most probably. The choice of antibiotic therapy is outside the scope of our session today and depend on the patient risk factors, severity of the disease, and the suspected causative organism, among the other factors. Moving to the next, this is pneumonia. We can also see proximal humerus fracture, which is the bone of the shoulder, because in chest radiograph you can review the shoulders bilaterally in the same chest radiograph. Here we have the normal humerus, and here is the fracture. The head of humerus is separated from the shaft of humerus with a slight angulation. This is the lesser tuberosity projecting inward. Humerus fracture. The fracture is most commonly at the humeral neck or at the greater trochanter, described with near classification in the last of the text. The scale only look at 4 parts of the humerus: the head, the greater tuberosity and lesser tuberosity, and the shaft. The grade is based on the angulation and displacement of those 4 areas: the head, greater tuberosity, lesser tuberosity, and the shaft. If a piece has 45 degrees of angulation or 1 centimeter displacement, it's considered separated. Okay, this is regarding proximal humerus fracture, because shoulder most probably can appear in a chest X-ray, because it is your responsibility to interpret any abnormality within the image, even if you request the chest X-ray for pneumonia, for example. Moving to the next, we have finished till the proximal humerus fracture. Sometimes we have pulmonary nodule. What is the abnormality regarding this image? You can notice this patchy area over here isn't consolidation and isn't normal lung parenchyma. You can notice again this patchy area. This is a nodule. Nodule can be due to multiple or many causes. Here we have nodule can be single or multiple, and may be difficult to visualize if they overlie a cardiac silhouette or are behind the dome of the diaphragm because their density. They might only be seen on lateral view sometimes, or CT chest, for example. Presentation: pulmonary nodule have many etiologies, including malignancies, rheumatoid nodules, granuloma, and more. Sometimes they can be benign, not always they are malignant. The management of pulmonary nodule: an important part in the workup of pulmonary nodule is comparing the film to a prior X-ray. Is it new or it's old? And the interval of its growth. If you have a chest X-ray of a patient 1 week ago and this nodule appeared, most probably will be due to infectious cause. But if it is interval like 3 years, for example, most probably it can be due to carcinogenic or cancer development. If available, after the workup may involve further imaging, a biopsy, or monitoring. The full management algorithm is beyond the scope of our session today. Moving to the next, we have discussed rib fracture and tension pneumothorax. So this all regarding the chest injuries. Lastly, aspirated foreign body over here. Sorry, I've shown the labels. We have normal lung in the right side and hyperinflated lung in left side. Because in the size of each lung are different, the left is more larger. This is why the air is trapped by the presence of foreign body. In this image, we can't visualize the foreign body, but we can assess with the history as the mother come to you as this is a child from his immature skeleton appear in chest X-ray. We can review over here the epiphysis of the humerus, means that this is a child growing bones still. Okay, and even over here, this is the child X-ray. So the mother came to you and said, my child have ingested or inhaled a foreign body. You can't see, you request a chest X-ray, but you can't see the foreign body itself. But there is a related signs that you can interpret through it, that there is a difference between the two lung fields in the right and left side, may indicate entrapment of the foreign body, like for example in left main bronchus over here, and it led to the air to get in but blockage the expiratory movement of the air from the lung to outside. So this is hyperinflated lung result. The presentation of aspirated foreign body, common injury in young children, usual presentation with shortness of breath or choking or coughing. The caregiver, means the mother, the parents, may or may not be aware that the child has inhaled anything. So you have to take a proper history from the parents. X-ray findings: the affected lung is usually hyperinflated due to air trapping. This can be accentuated on the lateral decubitus film with the affected lung down. It is very uncommon to see a foreign body on plain film, as most are radiolucent. The management of aspirated foreign body: the removal of foreign body via bronchoscopy, usually performed. This is regarding the chest injuries. After we finish, we will discuss some of our basics again. Here we have the 5 densities. Air is black, fat is intermediate, soft tissue more whitened than fat, and water also like soft tissue, and bones more radio-opaque, which is white. So it is between black and white. colors, and metallic objects which more denser. Here we have lines on X-ray represent the boundaries between the different two densities. Okay, moving to the next chest X-ray over here. In the normal heart below on the left, for example, both right and left border are clearly visible because of the heart soft tissue sit next to the lung air. Because of this contrast between them, air is black and heart is white, we can see the differences between them. This means the contrast in physics. On the right, the middle lobe of the lung is consolidated. Here we have infection or consolidation over here that obscure the normal cardiac border, not like in the normal chest radiograph. The next one, it is fluid filled given the density of soft tissue because of the consolidation. Since the heart and consolidated lung have about the same density, the right heart border become indistinct because there is no contrast between them. Then move to odd view to order. For the vast majority of applications of chest or X-rays, a single view is insufficient. Typically, you will want to order two orthogonal views. Orthogonals means different views or different angling at about 90 degrees to each other, like lateral and AB, for example. This will help you to visualize all the bones and better characterize fractures and associated injuries. Often, pathology will be visible on one view. Here we have the shoulder. Routinely, we do AB and lateral Y-shaped shoulder X-ray. We have some special views, then it is out the scope of this lecture. The shoulder AB and lateral Y view, elbow AB and lateral also, the wrist PA oblique and lateral most probably, and there is special other views. Hand we have PA and oblique views. In some conditions we apply some special views. In pelvis and hip, routinely we do AP with lateral if there is a specific concern of a unilateral hip injury. Most probably we do bilateral to compare between the two sides. The knee AB and horizontal beam lateral, foot AP oblique and lateral. C-spine, routinely we do lateral and AB, with AB big if there is suspicious of an injury of C1 or C2 fracture. We mean with big, the big is the part of the second vertebral, cervical vertebra, sorry. The second cervical vertebra is viewed in an open mouth view. We take like a skull radiograph AB with the patient opening his mouth, so to remove the mandible from the projection of the X-ray to visualize the back of C2 vertebra. So in cervical spine we do lateral and AB. Also, it should also be noted that X-ray can't rule out a ligamentous injury of the C-spine, cervical spine, and should never be used to clear someone from a C-collar. We should do CT for him. No common special views in cervical spine. It is lateral and AB most commonly used. Then we have, sometimes we use oblique views in cervical spine, sometimes. We have lumbar spine, AB and lateral views. Chest, AB and lateral views. Abdomen, AB. It should be noted that there are few indications for an abdominal X-ray, most significantly bowel obstruction and free air under diaphragm in erect X-rays. For example, For almost all other indications, CT or ultrasound will be the preferred test of choice, superior to X-ray. We have no special views in abdomen. This is regarding the common requested views in X-rays. Let's review them in hurry. We have, for example, the spine. We have cervical spine lateral view, and here the odontoid beak of C2 vertebra, here C1 vertebra. Ensure the arch of C1 is less than 3 mm from the beak, 5 mm in pediatric, 3 for adult and 5 in pediatric. Here, ensure the anterior and posterior cortex of the beak align with the body of C2 vertebra. Ensure Harris ring is unbroken anteriorly and posteriorly. Check each vertebral body. This called alignment, that every vertebral body is underneath the next and the above one. Check each vertebral body from C3, C7 for equal heights anteriorly and posteriorly, and this is called alignment, or means the linearity of the bones to each other, as we are drawing a line between them. Then we have 3 lines: anterior line, posterior line, and spinolaminar line. Ensure the anterior and posterior spinolaminar lines are smooth. Check the width of the prevertebral soft tissue. Widening, for widening, sometimes collection or abscesses, because this called the dangerous space. The soft tissue anterior to the body of the vertebra, this called the prevertebral soft tissue in gray color. Along anterior to C2 vertebra, it should be less than 7 mm. Anterior to C6 vertebra, it is more widened, it should be less than 22 mm when we measure it. This is regarding the cervical spine. We have some injuries like anterior cervical subluxation, compression fracture, hangman fracture, hyperflexion teardrop fracture, Jefferson fracture, odontoid beak fracture, spinous process fracture, transverse ligament rupture, unilateral facet dislocation. We will be discussed later these injuries. Moving to the lumbar spine. Lumbar spine, we have 5 vertebrae. In lumbar spine, we have L1, L2, L3, L4, and L5. We have facet joint between each posterior element, and the spinous process, the most projecting posteriorly. This is the normal lumbar spine X-ray, and S1 is the sacral vertebrae, and the T stands for thoracic vertebrae, where the ribs are projecting from. Then ensure the vertebral bodies are vertically aligned. This is the alignment, the linearity of the bones to each other. Ensure each vertebral body is intact with a smooth cortex. Check for bone fragments anterior to the vertebral bodies. We have 3 columns of dents. It calls 3 columns of dents. Anterior column involving the 2/3, anterior 2/3 of the vertebral body. Middle column involve the posterior 1/3 of the vertebral body and the spinal canal. The posterior column involve the elements posterior to the spinal canal. Assess spine for instability. Injuries in more than one column are unstable. Injuries are in less than in one column are stable. This is all regarding the lumbar spine. We have Perth fracture, compression fracture, flexion, distraction injury, vertebral fracture. Dislocation will be discussed later. This is regarding the lumbar spine views. We have shoulder. This is a B view of the shoulder, as we have seen before. We have some anatomical elements: the clavicle, acromion, the coracoid in yellow, the glenoid and humerus. This is the AB view. We have also this coracoclavicular distance should be less than 1.3 centimeter. Make sure the head of the humerus is not directly inferior to the coracoid. Ensure that the glenoid cavity parallels the articular surface of the humeral head. Check all bones in the view for fractures, including the ribs and body of scapula. This is a B view of the shoulder. We have some injuries: acromioclavicular joint disruption, anterior dislocation, pancreatic lesion, clavicle fracture, heel sac lesion, posterior dislocation, proximal humerus fracture, rib fracture, and Salter-Harris fracture will be discussed later in musculoskeletal lecture. Last, we have the abdominal radiographs. This is the diaphragm in abdominal radiograph, the gastric papille, air within gastric papille, the large intestine surrounding the small intestine inside. You have to locate a free air under diaphragm. Make sure there is no free air under diaphragm. This will be visible on erect film, which may indicate viscous rupture or perforation. Examine the inferior lungs for consolidation suggestive for pneumonia in abdominal radiograph. As you see the upper abdomen in chest X-ray, you have to review the lower chest in the abdominal radiograph. Ensure small intestine, if it is visible, is in diameter less than 3 cm, large bowel less than 6 cm, and the cecum and sigmoid less than 9 cm. So we have this rule called 3-6-9 rule. 3 for small intestine diameter, 6 for large bowel diameter, a part of the cecum and sigmoid, which are 9 cm. If the diameter of intestine increase or be beyond this might indicate the presence of intestinal obstruction, either small bowel obstruction or large bowel obstruction, and which is an emergency. This is all regarding this session. We have large bowel obstruction in this image, where the large bowel is dilated more than 6 in upper and 9 in cecum and sigmoid. This is the dilated large bowel with the loss of hastration, normal hastration of the bowel. Large bowel obstruction is much less common than small bowel obstruction. Most causes are caused by colon cancer, acute diverticulitis, or volvulus. Patients typically present with abdominal distension and pain, as well as failure to pass stool or flatus. It can be constipation for many days and obsolete or OBS constipation. At the sign X-ray, the most common finding on abdominal X-ray is colonic distension greater than 6 cm, cecum more than 9. The colon has infracted gas may be seen in the colonic wall, a finding known as pneumatosis coli, the presence of the air within the wall of the colon itself, or it calls pneumatosis intestinalis, the other name. Pneumatosis, presence of air. Intestinalis means the intestines, that presence of air in the intestinal wall, or there may be a free abdominal gas in suspected perforation, because bowel obstruction is an emergency because it can lead to bowel perforation. which is emergency. Management surgery is typically required, especially if the colon has infarcted mean ischemic insurance, or there is mass lesion causing the obstruction, so surgery will remove the obstruction. This is it. Small bowel obstruction. Over here we can see or visualize the small bowel located in the middle of the image. This is the small bowel with air fluid level within the small bowel. Small bowel obstruction is about 4 times more common than large bowel obstruction. The most common causes of are fusions from prior abdominal surgery, means adhesions from previous surgeries, incarcerated hernias, and cancer, but there are many other potential causes. Patient usually present with abdominal pain, nausea, and vomiting. X-ray findings. The classic finding on abdominal plain film are loops of small bowel dilated more than 3 cm for a small bowel, containing air fluid levels more than 3 also. Abdominal X-rays will only detect about half of all small bowel obstruction, so in many times we can proceed to CT. So if your clinical suspicion is high, get a CT. The management: aggressive fluid resuscitation, NG tube placement, analgesia, antiemetic, and surgery consultation are the mainstay of early management of small bowel obstruction. Surgery is indicated for the strangulated small bowel obstruction. Strangulated means the presence of ischemic part of the small bowel because its blood supply is compromised. This is regarding the abdominal radiograph and its pathologies. This is all for today. Thank you.